I've passed along with Avinash almost 12 years back from NIMS. We both were contemporary at that point of time, and we thought of coming up with a good hospital, giving service and quality treatment to either Karimnagar or Warangal. That's what we thought in the beginning, and finally we ended up in Warangal with such a beautiful hospital, and it was a dream come true project. And finally, 6 months back, we had started this hospital, and we have all the facilities. With Avinash will once again talk about that quality of LINAC radiation machine, the PET, the brachytherapy, everything we have, and the wonderful faculty we have. Avinash will again say a few words about that. And I am basically a medical oncologist. So today I would just like to briefly tell you something about immunotherapy, which is a fancy topic these days, and everybody would ask about immunotherapy or targeted therapy, and people will ask why these things have come up now and why chemotherapy still be given. So that is why I'm just talking and giving a few points about, telling you a few points about immunotherapy. Immunotherapy is a treatment that uses the person's own immune system to fight the cancer. Immunotherapy can boost or change how the immune system will fight the cancer. For example, with traditional cancer therapies like radiation or chemotherapy, which acts on the body and kills the healthy cells as well as cancer cells. With, few side effects. We cannot say there are many side effects. There will be side effects which will be reasonable and manageable. Don't go with the slide. So with cancer immunotherapies, immunotherapy just boosts the immune system of the patient, and therefore it targets only the cancer cells, not the normal cells. For example, PD-L1 is a ligand on the tumor cell. This one is PD-L1, it is on the tumor cell. PD-1 is on the T cell. When there is fusion of PD-L1 and PD-1, the immune system is blocked. This is what happens in all the patients. So what we do is we give a drug which will target either the PD-L1 or the PD-1. It will block it. So once PD-1 is blocked, PD-L1 will not bind to PD-1 and the immune system is activated. As simple as that. For example, Keytruda, that is pembrolizumab, is the first immunotherapy drug approved elsewhere in the world as well as India. So we have used this pembrolizumab in almost, I've given almost 11 chemotherapies till now, and in three patients, total 11 chemotherapies. Pembrolizumab can be added to targeted therapy like bevacizumab. It can be added to chemotherapies. Based on something called a tumor mutational burden, I'll decide whether this pembrolizumab will be given as a monotherapy drug or will be combined with chemotherapy. So this is how pembrolizumab acts on the body this way. If there is a possible fusion of PD-L1 with PD-1, I'll give this drug and the fusion is blocked, therefore the immune system is activated. This is the same slide showing how Keytruda acts. PD-L1, PD-L2 ligands binding to PD-1 receptor. I give Keytruda, block the fusion, and therefore the tumor cell is destroyed. This is another drug by name atezolizumab. Atezolizumab, the brand name is Tecentriq. There are no, it's time only for innovator molecules, and there are no generic molecules right now. So we can call it as Tecentriq. So I have given atezolizumab for 2 patients. One is in carcinoma lung and the other is in renal cell carcinoma. In carcinoma lung, I had to combine it with pemetrexed and carboplatin chemotherapy because the tumor burden was low. And in RCC, we don't need to check the tumor burden, and I had combined it with cabozantinib. This is another drug by name nivolumab, Opdivo, is also an immunotherapy drug. It also blocks the PD-L1 ligand, and we predominantly use this in malignant melanoma, non-small cell lung cancers, as well as squamous cell carcinomas of the head and neck. So I have used this in almost 11 doses, maybe in 2 patients. This is another slide showing the fusion of PD-L1 to PD-1. Once nivolumab is given, the fusion is broken and the tumor cell is destroyed because of the activity of immune system. The fusion of PD-L1 and PD-1 blocks the immune system. Once we break this fusion, immune system is activated. This is another drug by name Imfinzi, durvalumab. This had got an accelerated approval in phase 2 trials and was in the market for almost 8 months to 9 months. And after that, because it failed to show good results in phase 3 trials, the drug was withdrawn from the market. Now it is not approved in India. So the only drugs as of now approved in India are pembrolizumab, nivolumab, and atezolizumab, which I have already shown those 3 drugs. This is another slide showing how atezolizumab and durvalumab they act. Another slide showing the same thing. Atezolizumab can be used, durvalumab can be used in small cell lung cancer. When atezolizumab is combined with bevacizumab, which is again a targeted therapy, which is a VEGF blocker. Once bevacizumab blocks something called VEGF, it's a ligand. When this blocks the VEGF ligand, the fusion of VEGF to VEGFR is blocked, and the downstream activity like proliferation, vasodilatation, and the entire survival of the microvasculature is blocked, and therefore the tumor becomes vulnerable to chemotherapy. Therefore, these immunotherapies and monoclonal antibodies are usually combined with chemotherapies. Even today, chemotherapy is the mother treatment. So these monoclonal antibodies, immunotherapies are used to boost the chemotherapy effect. Unless the tumor burden is very high and the PD-L1 levels are very high, we cannot use monotherapies. If the tumor burden is very high, we can use monotherapy, that is immunotherapy as a single agent. This is another drug which is a monoclonal antibody used in multiple myeloma. It is specific called CD38. Once daratumumab is given, CD38 is destroyed. We have to identify whether CD38 is there in the multiple myeloma cell or not. So I give daratumumab, it destroys CD38. Once the CD38 is blocked, the cell dies with antibody-dependent cellular toxicity, complement-mediated toxicity, and such activities. A few words about something called tumor mutational burden. It is nothing but the total number of mutations in the DNA of the cancer cell. We assess it by something called number of mutes per megabase. And the test which is done to assess to know how much tumor mutational burden is there in the cancer is by NGS panel. That is called next generation sequencing. This next generation sequencing will tell me whether I can use a single drug immunotherapy or whether I have to use immunotherapy plus chemotherapy. So I'll get to know that with next generation sequencing. And I also get to know about the prognosis, like sir asked which cancers are good, which are not good. So I'll get to know the prognosis also with next generation sequencing. So I'll get to know the tumor mutational burden and the PD-L1 levels. If these things are favorable to the patient only, immunotherapy will be used. Immunotherapy will not be used for all the patients. Many doctors keep asking me, why not immunotherapy? Can we give immunotherapy to this patient? It depends on what exactly the tumor mutational burden and the PD-L1 levels. So high TMB, more likely that the immune system attacks the cancer cell. So by default, the highest tumor mutational burdens will be in melanomas, squamous cell carcinoma of the head and neck, and non-small cell lung cancers. Therefore, in melanomas and squamous cells, we don't usually check TMBs. We directly give immunotherapy. But when it comes to non-small cell lung cancer, or like sir asked in adenocarcinoma of the colon, or RCCs, or urothelial carcinoma, we have to check whether TMB is high or not. If the TMB is high, we use immunotherapy, and if the patient is affordable only, that is also one factor. Just a brief thing about, I think monoclonal antibodies, many are familiar about this already. So there are a few more drugs by name cetuximab. Cetuximab is a wonderful monoclonal antibody, acts against EGFR receptor. My radiation colleague, if the patient is not fit for chemotherapy, concurrent radiation, he combines it with cetuximab. Radiation will be combined with cetuximab in squamous cell carcinoma of the head and neck, and he gets good response. But the usual classical mother treatment is always a chemotherapy drug along with radiation in cervical cancers or head and neck cancers. If the patient is not fit for chemotherapy, then only cetuximab can be given. So there are other beautiful drugs like rituximab, just like I just told, we were discussing about non-Hodgkin lymphomas. So if CD20 is positive, I would like to use rituximab along with chemotherapy. So daratumumab is one monoclonal antibody used in multiple myeloma if it is CD38 positive. Trastuzumab if it is HER2 positive in breast cancer. Pertuzumab if it is HER2 positive in breast cancer. TDM1 breast cancer. So all these are called targeted therapies. So the science has changed now. It is not only chemotherapies. We have to use monoclonal antibodies, check the receptor status, see whether the patient is financially and scientifically fit for the immunotherapy and monoclonal antibodies, and accordingly we have to start. Side effects with immunotherapy, almost none. Fatigue, pruritus, nausea, altered bowel habits are all manageable and very reasonable. So literally we can say there are hardly any side effects with immunotherapy. Just a single picture will tell us, this is the initial cancer for this patient. And once we combined it with immunotherapy and chemotherapy, this is the picture, just after 2 cycles. So the responses will usually be very amazing. Immunotherapy when combined with chemotherapy. So these are all other targeted therapies. Even small molecule inhibitors are also targeted therapies. We all know about the drug imatinib used in CML. There are next generation drugs like nilotinib, dasatinib, bosutinib, ponatinib. I would like to again in future, I'll definitely promise to come up with more CMEs, more updates, and we shall discuss about the molecular pathology of one particular cancer next time. The drug, how the drug is used, what are the side effects. In each cancer we can discuss. So in future we'll come up with more CMEs and more discussions. These are all other targeted therapies. So right now we have 3 kits with acute lymphoid leukemia patient, acute lymphoid leukemia treatments, and we have completed 2 acute myeloid leukemia inductions and waiting for consolidations. And we have 5 acute myeloid leukemia patients with a moderate drug called azacitidine and another drug called venetoclax, a recent drug. Even this is a targeted therapy. So when venetoclax is attached to, when combined with azacitidine, we get good responses. We have 5 patients on AML right now. And as I said, we have given escalated BioCorp regimens in relapsed Hodgkin lymphomas. Why I am talking about these protocols and treatments are that it is not easy. This requires experience. This requires good counseling. This requires definitely finances also. All these things are important. It is not just about a medical oncologist doing it. This requires experience. So we are lucky that we have a full-time interventional radiologist for immediate biopsies and FNACs, so that I can start timely chemotherapies. We don't need to send the patient to other centers to get the biopsy. We don't need to worry whether the biopsy is done properly or not. We have an in-house radiologist for all these. An expert surgical oncology team, they give me chemoport insertions. They insert chemoports. Chemoport is a method where we can give chemotherapy without securing IV line. It is inserted into the subclavian vein directly. Chemoport, once it is inserted, we can go for as much as 500 to 600 pricks also. It can be saved for 5 years also. So once the chemotherapy is in place, we can give good and prolonged chemotherapies. All our surgical oncologists can insert chemotherapies. Even this is a special technique. In the last 10 years of Karimnagar, I have given only 2. In 6 months in Warangal, we have given 90. So that is the quality of staff we have. And once we counsel the patients also, they'll also be ready once they come into such kind of hospital. So 19 chemotherapies, 47 targeted therapies in just 6 months, which is as good as any other corporate hospital in Hyderabad. Many leukemias inductions we have done. And continuing from my Karimnagar time, I have total 127 CML patients, which is also a big number. These CML patients will be on lifelong treatments, and I have my patients getting continued from Karimnagar. And 23 CML patients we have started in our hospital, and 104 chemotherapies continued from Karimnagar. So briefly, this is what we have achieved in medical oncology perspective. Thank you. Sarcomas through blood vessels.
But can't you give a good, carcinomas will have a good prognosis comparatively sarcomas. Can't you give a good management, immunotherapy with sarcomas to have a good prognosis?
Sir, immunotherapies in sarcomas have no good results as of today. Trials are on, but sarcomas, there are no good results with immunotherapies now. Immunotherapies are best approved in head and neck cancers, non-small cell lung cancer, colon cancer, RCC and urothelial carcinoma, and melanoma a little bit. Other than this, no other soft tissue sarcoma has got immunotherapy approval. Even they are not successful in phase 2 trials also. So as of today, for soft tissue sarcoma, depending on the type of sarcoma, chemotherapies are the only management. And there are few small molecule inhibitors with very modest response. So chemotherapy, timely initiation and timely surgery is very important.
Out of these leukemias, lymphoblastic leukemia will have a good prognosis comparatively with myeloblastic leukemia.
Again, sir, again depending on the age, depending on the type, depending on which type of AML the patient has got, depending on what is the fitness of the patient, age of the patient. A child with ALL is always a fantastic disease than any other solid tumors. So an adult with ALL is a bad disease. Type 3 AML is a good disease, that is promyelocytic leukemia. They are curable diseases. Type 4 AML, good disease. Type 2 AML is good disease. Otherwise, M0, M1, M5, N6, M7, they are all bad prognosis. It depends on what is the fitness of the patient, what is the type of AML, what is the fitness and age of the ALL child. Less than 1 year old kid, bad prognosis. More than 10 years old kid, bad prognosis. Multiple genetic testings have to be done, whether it is TEL AML positive in ALL, whether it is BCR-ABL positive in ALL, whether it is MLL gene mutation. There are multiple things. Based on the mutation analysis, we decide whether this patient requires which type of chemotherapy. Few will require small chemotherapies, mediocre chemotherapies. Few will require induction chemotherapy in the first month and followed by transplant directly. Few won't require transplant depending on the molecular analysis. So many things come into picture. So ALL, there's nothing like ALL is good in one, ALL is always good or AML is always good. It depends on what patient has got which disease.
What could be the response of multiple myeloma?
Sorry, sir?
Multiple myeloma.
Multiple myeloma. Generally, sir,
Yeah,
multiple myeloma is a reasonably good disease, sir. Even again, multiple myeloma depends on the molecular testing, cytogenetics, age of the patient also. So we determine whether they belong to low risk category, intermediate risk category, or high risk category based on the cytogenetics. So based on the cytogenetics, we decide which patient will require what treatment. For example, a low risk category patient will require almost 4 months of regular treatment followed by maintenance for 2 or 3 years. A high risk patient will have to be taken for transplant, autologous transplant. Immediately after 12 doses of the proteasome inhibitor, that is again a targeted therapy. After that, we have to take the patient for transplant. We have to decide upfront whether this patient goes to transplant or will go for maintenance therapy. Low risk patient will go for maintenance therapy, high risk patient will go for transplant. There are high risk patients after transplant surviving for 13th year in Warangal. I won't mention the name, Big Shot's wife. So the patient is still surviving, high risk patient, transplant, double transplant and 13th year. There are low risk patients who die after maintenance also. So multiple things come into picture, sir. Finally, it is God's grace which is important.
Thank you, sir. Thank you.
Currently now with good investigation facilities, many cancers are diagnosing early. Yeah, thanks for the investigations and inventing all these things. So especially carcinoma of the mouth, carcinoma of the breast, carcinoma of the cervix, carcinoma of the prostate. These will be diagnosed early and there will be surgical treatment is over. In those cases, do you advise chemotherapy plus immunotherapy or only chemotherapy to prevent recurrence? Because already surgery part is over and all the investigations it is evaluated, they are not having any cancer. In that cases, do you advise? Because it will come, recurrence will come after 5 years or 10 years, we cannot say. Mouth cancer, breast cancer, and cervical cancer, and prostate cancer. In that case, after surgical, without any secondaries, do you, what treatment you will advise? Whether immunotherapy, do you advise or not?
Simple, it's a very simple statement. No treatments will be given in follow-ups. Once the surgeon determines that surgery is done well, and he'll also determine, and the radiation oncologist also will determine whether they'll require radiation or not. Once this surgery and radiation, plus or minus, is over, they don't require any chemotherapy. It is follow-up, that's it. And there are no guidelines also. We should not give prophylactic chemotherapy. There is no prophylactic chemotherapy like prophylactic, and generally saying prophylactic antibiotics will be there, but prophylactic chemotherapy will not be there. So recurrence is prevented only with thorough follow-ups. So we have to catch the recurrence at the earliest stage again. Earliest stage. If the recurrence is local, again they'll operate. If the recurrence is metastatic diffuse, I'll have to give chemotherapy. But like you have asked, there is no such thing called prophylactic chemotherapy nor immunotherapy also. In few cancers like breast cancer, there is something called maintenance antibody. So if those particular culprit receptor genes are positive in the test we perform in IHC, we give something called a monoclonal antibody called trastuzumab or pertuzumab, which is given for over 1 year, over 18 times over 1 year. So except for few things like this, and except for some maintenance treatments in multiple myeloma, and few maintenance treatments in prostate cancer, these are all tablets, sir. Any prophylactic or maintenance treatment should be non-toxic. So the monoclonal antibody which I was talking in breast cancer, the drug which I'm talking in prostate and multiple myeloma, they are non-toxic. So we can continue for a year or so. But toxic chemotherapies cannot be given for long time, and there are no approvals for prophylactic chemotherapies. It is thorough follow-up which is required.
Carcinoma of the brain, tumor brain,
Sir.
and adenocarcinoma of the pancreas.
Sir.
So where we cannot already lately diagnosed and having secondaries. And what is your advice?
Pray to God, sir.
Only chemotherapy or immunotherapy?
Nothing, sir.
Or?
Pray to God. That's it. Recurrent brain tumors and carcinoma pancreas upfront 6 months lifetime, sir. As I said, the more they survive, more will be the problem. So 6 months is optimum time. They have to die in 4 to 6 months.
In your experience, you tell me 3 conditions where immunotherapy is 100% is treatable.
Immunotherapies?
Immunotherapy is 100% treatable.
Immunotherapies?
The treatment of immunotherapy, just tell me 3 conditions where it is 100% is curable. That I want. Just 3 conditions, any 3 conditions, cancer conditions. Please tell me.
I'll tell you 2, sir, not 3, because third is not good. Good results are seen in head and neck cancers and lung cancers. Head and neck cancers and lung cancers. These 2 cancers, immunotherapies are they have given very good results. We have been using it in urothelial carcinomas, RCC, in melanomas. Basically, they are very bad cancers. Whether we use immunotherapies or not, it doesn't really matter. Only an affordable patient who wants an extra response, extra 10% response will be benefited. Yes, sir. Excellent response we get. It depends on the tumor mutational burden. If the tumor mutation burden is more, for example, if the tumor mutation burden is more than 50%, we don't need to use chemotherapy at all. Only immunotherapy will work with amazing responses. There are patients with complete response in PET scan. PET scan showing 100% disease, and after 6 cycles of pembrolizumab monotherapy, there is complete response. No active disease at all else anywhere in the body. So such kind of results are possible in head and neck cancers and non-small cell lung cancers, predominantly lung cancers.